Are you Black? Do you have high blood pressure? Have you heard that Black patients need different medications than others? Well, let's break down that science, because you're not completely wrong, but you're not completely right. In this video, I'm going to discuss two main trials and how that impacts physicians on how we decide to recommend certain treatments versus others. And we'll also discuss briefly the American Heart Association, the American College of Cardiology's updated 2025 hypertension management framework. So let's begin. Doctors are following the updated 2025 American Heart Association, American College of Cardiology's framework for hypertension guidelines. We set targets based on the patient's individual risk factors and their overall risk for having cardiovascular disease and outcomes. When I say cardiovascular disease, I'm talking about strokes and heart attacks, and outcomes also include deaths or mortality. And we can use modern calculators such as Prevent, which was found in 2023. And in this particular calculator, it takes various demographics such as gender and cholesterol results. It also factors in whether or not they're smoking and systolic blood pressure reading. The basic calculator from the American Heart Association does not include zip code, but it is an added option for many online versions of this calculator. I personally have not used the zip code option, but I can understand the role of using a zip code to better understand the patient and their entire risk profile. And this actually helps my colleagues and those who do use it in advocating for appropriate counseling and treatment interventions. So, for example, when it comes to choosing a target, a Black individual may require the stricter blood pressure target of 120 versus 130 just because they have a higher risk for developing cardiovascular disease and outcomes. Whereas a 130 or higher target may be more appropriate for someone who's healthier and has less of a risk for developing heart attacks and strokes. When we do choose the target, it's very important for us to consider the risks versus benefits. Nothing is entirely safe, including whether it's a pill, a procedure, or the like. So whenever we choose or make a decision for you, and we'll involve you in the process, we're trying to maximize your benefit and reduce the risk or further harm to you. So let's talk about the SPRINT trial. This is a trial that looked at 9,361 high-risk adults without diabetes. 2,800 were non-Hispanic Black patients. Now I'm going to interrupt here and say why this is important. When we review the trials, it's very difficult to take the conclusion of a trial and apply it to a particular demographic group or ethnicity, unless there are adequate numbers represented. 2,800 is a good-sized number. But most of the time, when we're making recommendations and when the societies are created guidelines for how to treat patients, we are extrapolating the data from your strong studies that have thousands of individuals, sometimes tens of thousands, and using that to apply to our patients. It is difficult to prove that the study results that worked in this particular studied group will apply to our patient who's a minority or doesn't really reflect that. And we take that into consideration. But with the sparing amount of research dedicated to people of color or other minority groups, it is difficult to really find something that is just unique. So back to the study. They measured intensive systolic blood pressure targets of 120 versus 140. And they found that the more strict control of a systolic blood pressure of 120 actually had a better reduction in cardiovascular disease outcomes compared to those who were targeted at 140. Now, there were side effects noted, such as those that had the stricter target of 120 actually had syncope, they fainted, their blood pressures dropped, they often had kidney injury or acute kidney injury develop that was reversed, and they also had electrolyte deficiencies. There was no difference in injurious falls from the low blood pressures. They did do a subgroup analysis looking at Black patients within that study, and they found that the strict lowering or target of 120 versus 140 was actually just as beneficial to Black patients as to non-Black patients. Let's look at the other study called the AASK. In this particular study, they looked at 1,094 African American participants with long-standing high blood pressure and kidney disease from hypertensive nephrosclerosis and generally mild proteinuria. What does that mean? Before I dive into further details of the study, I want y'all to know that hypertensive nephrosclerosis is a condition in which long-standing high blood pressure, we're talking about over years, damages the kidney to the point where it can't filter very well. Our kidneys have these microscopic units called glomeruli, which I like to call the filters. Not only are they responsible for removing the toxins and impurities from the blood and excreting them into the urine, they also help ensure that none of the protein is lost. When the kidney filters damage, then we lose valuable amounts of protein, and that is measurable in the urine. So in long-standing hypertensive nephrosclerosis and long-standing diabetes, this type of damage can develop where there's too much protein spillage in the urine. They compared ACE inhibitors, which was ramipril, versus beta blockers, which is metoprolol, versus amlodipine, which is what we call a calcium channel blocker. And they found that when it came to kidney outcomes, such as going on dialysis or dying, the ACE inhibitors had a reduction in those outcomes compared to the calcium channel blockers. They also found that in those patients whose glomeruli or filters are damaged from long-standing disease, whether it's high blood pressure or diabetes, those patients had a protective effect from being on the ACE inhibitors. Why does this matter? In Black patients with kidney disease, the ACE inhibitors in ARB category actually protected their kidneys versus those that didn't, such as the calcium channel blockers or the metoprolols. But what was important to know is that in those Black patients that did not have kidney glomeruli damage or proteinuria, the spillage of protein in their urine, there wasn't a difference of effect that was superior to the ACE inhibitors versus the calcium channel blockers. So the sum of the study was that if the patient has high blood pressure and they have kidney damage with a result of protein spillage in the urine, then the ACE inhibitors and ARBs were a better option to treat their blood pressures. Now, the caveat of that is that there is a side effect called angioedema, which is where the lips, the mouth, the throat, and the neck can swell. It can be some, it can be all, it can be just one. And this doesn't necessarily happen within days or weeks of starting the medication. In fact, it can happen after years of being on the medication. So if there's a patient that has a history of developing this in response to ingesting seafood or shellfish or almonds, or even having an allergic reaction to dye that is used in radiologic studies, then they should not be on this medication. But outside of that, minus that history, this is a good choice. So in summary, let's talk about the medication classes. ACE inhibitors and ARBs are usually lumped together, and they're great for people who have heart disease, such as heart failure, coronary artery disease, and patients who have kidney damage with the spillage of protein, as we were referring to earlier. You want to monitor by checking a creatinine level, which indicates kidney function, and potassium within 1 to 2 weeks of starting the drug. And then afterwards, regularly every 3 to 4 months is a good rule of thumb. The next class is thiazide type diuretics. So we're talking about chlorothalidone and hydrochlorothiazide, or HCTZ. These medications are a great add-on. They can also be used alone, but they can also be associated with electrolyte abnormalities. So you want to check the electrolytes, the sodium, the potassium, the creatinine 1 to 2 weeks after starting these medicines, and then regularly thereafter. They can also cause leg cramping. We have our dihydropyridine calcium channel blockers, such as amlodipine, also known as Norvasc. And this particular medicine is also a good medicine in terms of lowering blood pressure effectively, but the side effect of this is edema. We also have beta blockers, which are great additives, but they're not usually your first line for just blood pressure management. If the patient, however, has heart failure, has heart disease, such as in the form of coronary artery disease, they've had stents, they've had a heart attack, then the beta blocker is a good choice to add. Often you have 2 medications and 1 pill, and these can be more cost effective in the long run as opposed to buying them individually. So now let's conclude with the race and ethnicity proportion. When I was in medical school, we were taught to use a framework when presenting our patient population. Mr. John Smith is a 45-year-old African American male with blah, blah, blah. That terminology has been phased out. I still see some patients and some students in medical schools all over the world use that language, but we found it's not really helpful, especially since it doesn't really change much in management just from that one term alone. What is more important is your social determinants of health. The stresses that the patient deals with on a daily basis can have a big impact on blood pressure. For example, food choices and food insecurity, stress from work, the lack of reliable housing or any housing, the lack of transportation. The list is pretty long. Coexisting depression, being the single breadwinner, facing financial insecurity, being underinsured in terms of health insurance. These play more of a role than a person's race. And if you think about it, there are some correlations, and the more important focus for us as physicians is to ascertain specifically what those social determinants of health are so we can provide appropriate counseling. One of the things that I have focused on that should be easy for all patients to do, for the most part, is to keep a blood pressure log at home. This is so necessary for giving the physician an idea of what the blood pressures run at home. We want to know mornings, nights, throughout the day. From that log provides more information than the handful of blood pressure recordings we get while you're in the hospital or that one visit in the clinic. Culturally appropriate DASH. In a previous video, I talked about the dietary approach to stopping hypertension, and it's easy for me to recommend fruits and vegetables, but it's harder to do in practice. For Black patients, however, I want y'all to focus on beans, greens, and leans. Leans meaning lean proteins. And then think about preserving the spices that y'all use, but trying to incorporate more of these vegetables and less red meat. Also cut back on the salt. 2,100 milligrams, 2,000 milligrams or less would be preferred. Sleep apnea is underdiagnosed. If your partner tells you that they've noticed you stop breathing or you snore, talk to your physician and get a referral for a sleep study. Sleep apnea can raise blood pressure. When undiagnosed and unmanaged for years, can cause damage to the pulmonary arteries, which can lead to all sorts of problems such as shortness of breath and fluid buildup that can't easily be removed and treated. Try to focus on incorporating physical activity. I like to say it's 150 minutes a week, which is 30 minutes per weekday. Additional lifestyle management that I like to recommend is weight. So a loss of 5 to 10 pounds may seem small to you, but can lower your blood pressure by up to 10 points. This is critical because even 10 points is a major change for the organs of your body. They will sense that lack, that reduction in such strong force, and it will help prevent further kidney damage. Alcohol and NSAIDs. Now, none of us are taking NSAIDs because we like to. We take NSAIDs because we're in pain. But there is a slight increase in blood pressure when that's taken. And then when it comes to alcohol, even though it's known as a depressant and most people's pressures are lowered, there are a few individuals who will have high blood pressure when drinking alcohol. And then follow up. Follow up with your physician every 3 to 4 months or as they advise. It's important to know what your labs and electrolytes are on these medications. I like to tell people that kidney damage is silent. It will not cause pain unless the pain is from a kidney stone, which can also cause damage. But most of the damage that's happening is medical. It's silent. You're not going to know about it. It's only detected on a lab result. When you're having side effects, your physician wants to know. When your electrolytes are changing, we're going to want to know that. We're also going to want to know what works. and we want to have that opportunity to provide you appropriate counseling. I hope this video was helpful for you to better understand why we choose targets and what we factor in. If you like this material, give me a thumbs up and subscribe, and follow me for more Medicine Makes Sense. Until next time.